Hi, I'm Aslyn,
And I'm Rebecca.
And I'm Lacey.
and our Best Bet presentation is titled Home-Based CIMT to Improve ADL and IADL Performance in Adults with Post-Stroke Hemiparesis.
So for our case study, we chose a 66-year-old male named Richard. Richard is recently retired, and he has also recently experienced a stroke that has left him with some hemiparesis in his right arm. Before the stroke, Richard was independent in ADLs as well as some IADLs, and he is also pretty active with his family and goes to church every week. So Richard completed the COPM, and that has shown us that he has some difficulty using both hands to cook and garden and do some of the other things he used to be able to do without trouble. And Richard has indicated some concern about the integrity of his right arm because he's noticed that he's tends to use his left arm more. So that brings us to our evidence-based occupational therapy question, and that is, in adults with hemiparesis resulting from stroke, is a home-based version of constraint-induced movement therapy, or home CIMT, effective in improving performance in ADLs and IADLs?
So for inclusion criteria, we wanted to include the peer-reviewed studies, but if it wasn't a peer-reviewed study, we wanted sources that were specific to occupational therapy. For example, we had an expert opinion article from an AOTA journal. We were open to all levels of evidence published within the time frame of years 2000 to 2016 and written in the English language. If the research was considered an intervention study, it had to include performance-based outcome measures. However, we did not include any study protocols, narrative reviews, reports, dissertations, theses, or presentations that were published before 2000 or those that were not within the scope of occupational therapy practice. And for the search results, we performed 4 database searches in Medline, CINAHL Complete, the Nursing and Allied Health Database, and Academic OneFile. We purposely wanted to conduct a broad search with the Nursing and Allied Health Database because we weren't able to obtain many articles from the first 2 searches, and the ones we were seeing were redundant. So instead, we performed a broad search purposely in hopes of bringing in several articles that we had not previously seen. We found 2 articles within the Level 1 evidence, one of which was an RCT, and the other was a randomized 2-group intervention. We were able to obtain 2 articles for Level 2 and 1 article for Level 3 evidence. We had the most studies within the Level 4 evidence. Our 1 Level 5 article was an expert opinion from OT Magazine, and we had 1 qualitative study. Overall, we obtained 11 relevant articles from our search.
Our first summary of Level 1 and 2 evidence included 1 RCT, 1 randomized 2-group intervention, and 2 non-randomized 2-group intervention studies. Many of them found that the home CIMT improved participants' motor function, quality of arm use, and were able to perform ADL and IADL tasks in a more timely manner. In fact, at times these improvements were similar to those who were in the classic CIMT control group. However, in Azab et al.'s study, their treatment group was also receiving OT services for about 40 minutes, 3 to 4 times a week for 4 weeks. So therefore, it's difficult to infer if improvements occurred through the home CIMT protocol alone or if the OT services had some influence on that. One study found that there was no significance in upper extremity use between those in a home CIMT group versus those receiving neurodevelopmental treatment, although the CIMT group did exhibit positive benefits as their baseline scores indicated. But overall, all of these studies demonstrated strong rigor other than the non-use of randomization techniques in the 2 Level 2 studies. Groups were similar at baseline and they received similar treatment. For the remaining evidence, this summary included 1 group pre-test, post-test design, 4 Level 4 evidences, including several SSRs and case studies, 1 expert opinion article, and 1 qualitative study, which in fact used mixed methods approach. Reasons for implementing the home CIMT protocol varied. One study specifically looked at if repeating CIMT years after a stroke was still beneficial to upper extremity function, while others implemented a home-based CIMT protocol because patients were required to have home health services. Home CIMT protocols could involve caregiver assistance, where someone was trained to provide the intervention, while others require that the participants had the sole responsibility for their compliance. The presence of a caregiver, however, was not always considered to be a variable, and this additional support could have influenced the results. Our qualitative evidence indicated that the home CIMT protocol was perceived as beneficial, and the 2 participants expressed they plan to continue engaging in the intervention principles even after the study was done, hoping that they would have greater functional gains in their upper extremity that was affected. Overall, while these studies provide support that a home-based CIMT is an effective treatment strategy, most of them were limited by small sample sizes ranging from 2 to 8 participants, a lack of blinding and randomization, and a lack of repeated baseline measures. So this makes it unclear if results are due, again, to the intervention itself or simply the natural recovery process.
So all our research and our research appraisals have brought us to the clinical bottom line, and that is that home CIMT does improve performance in ADLs and IADLs by improving upper extremity function and reducing the time needed to complete tasks. Across various studies, the results were similar whether or not the participants had had the stroke recently or not recently. For example, the repeat study we referenced before had participants that experienced their stroke anywhere from 3 to 26 years ago. And another factor that's important to note is that caregiver participation during the implementation of home CIMT should be considered to optimize outcomes for future patients. And home CIMT is also potentially a good option for patients or clients who, for whatever reason, can't receive treatment in the outpatient clinic.
So as we know, CIMT is a common intervention that's already performed in adults with hemiparesis, as well as children with hemiparetic cerebral palsy. This home-based version can continue to enhance occupational performance in ADLs and IADLs, as well as leisure activities. The protocol in these studies were also flexible in that the OTs designed the therapeutic activities based on the participants' goals and interests, and this coincides with the OT philosophies, client-centered care, and looking at a client in a holistic manner. As OT practitioners, we also need to recommend services based on their personal and environmental factors. So if we know a client may not have the means to travel, as we said, to an outpatient setting, offering this intervention may be appropriate.
So continuing education may need to be offered to professionals, perhaps in the form of a continuing education conference or a self-paced clinical course similar to those offered by the AOTA, or an in-service session. And this course or training session should detail a standardized protocol for home-based CIMT and should include all the CIMT guiding principles, and also give professionals some information on how to educate clients on the program and motivate them to comply with the program.
For future research, we found that there's a lack of evidence for randomized control trials for this topic. Of the current research, most study designs consist of case studies and single subject designs. It is critical to conduct more RCTs to ensure reliability of intervention studies through obtaining a larger pool of subjects achieved through complex sampling procedures in order to reduce bias, as well as perform multiple baseline measures. In addition, standardized procedures of a home CIMT protocol will eventually need to be established in order for OT practitioners to provide consistency in their intervention.
And that includes our BestBET paper, and we provide our references that we used in the slides afterwards. Thank you so much.